Welcome to Roadmap to Residency. Hello everyone, I am Abhiras. Welcome to our Club 250 Matchmaker sessions. We will be running through a few questions with you guys on your journey to a 250. So whenever you encounter a USMLE style question, the first thing you need to do is you want to read the last line first. Now this will give you an idea about what to look for in the question, in the question stem, the long question stem, what all the tips, what all the notices you need to point out. So we have here, which of the following is the most likely cause of this patient's symptoms? So now here we know that this question is talking us about the cause of this patient's symptoms. Now let's find out what is this patient all about. Now here we have a 56-year-old woman who comes to the office due to progressive weight gain and fatigue over the last 4 months. She also has had increasing difficulty in lifting heavy objects and climbing stairs. The patient has moderate persistent bronchial asthma for which she uses inhaled corticosteroids and beta-2 agonist. Now, family history is significant for colon cancer in her father. Blood pressure is 160 upon 90, which is quite elevated, and the pulse is 80 per minute. On physical examination, there is a symmetric proximal muscle weakness of the upper and lower extremities. Now, the fasting plasma glucose level is 135 milligram per deciliter, and 24-hour urinary cortisol is increased. The further evaluation reveals that high dose but not low dose dexamethasone suppresses the serum cortisol levels. The serum ACTH levels are high normal. So which of the following is the most likely cause of this patient's symptoms? Adrenal adenoma, adrenal carcinoma, exogenous glucocorticoids, pituitary adenoma, and small cell lung cancer. So here you can just pause the video and think and try to answer yourself what is the answer. So the correct answer here is pituitary adenoma. So the patient has weight gain, proximal muscle weakness, hypertension, and hyperglycemia, which are prominent features of Cushing syndrome. Now, the screening tests for endogenous Cushing syndrome include low-dose dexamethasone suppression testing. Now, in normal individuals, low-dose dexamethasone suppresses the ACTH and cortisol levels through negative feedback. Now, however, in endogenous Cushing syndrome, ACTH and cortisol levels are not suppressed. The most common cause of Cushing syndrome are uh, we will be discussing that, okay, and can be categorized on the basis of serum ACTH levels to be either ACTH dependent or ACTH independent, okay. So ACTH dependent is where the ACTH is high or inappropriately normal, or ACTH independent where ACTH is suppressed. Now, in ACTH dependent Cushing syndrome, if high dose dexamethasone suppresses the ACTH and cortisol secretion, a pituitary source of ACTH, that is, an ACTH secreting pituitary adenoma is more likely, right? So we will now just skim through some of the basic concepts regarding Cushing syndrome. So what is actually Cushing syndrome? So Cushing syndrome results from excessive levels of glucocorticoids due to any cause, but the cortisol is the principal glucocorticoid. Now, Cushing disease, however, it results from an ACTH secreting pituitary adenoma, so thus a pituitary cause of Cushing syndrome. So our patient typically had Cushing's disease, right? So Cushing syndrome and Cushing disease don't confuse much, okay? Both of these diseases, there is excessive level of glucocorticoids, right? But Cushing syndrome is actually due to the excessive level of glucocorticoids due to any other cause rather than the ACTH secreting pituitary adenoma. If there is ACTH increased due to the pituitary adenoma, then that is called as Cushing disease. Now let's talk about some of the causes of the Cushing syndrome. Now the first of all is iatrogenic. So iatrogenic Cushing syndrome is the most common cause and is due to the prescribed prednisone or other steroids. Androgen excess is absent because the exogenous steroid suppresses the androgen production by the adrenals. But the Cushing disease is the most common cause and leads to the bilateral adrenal hyperplasia, and androgen excess is common. Now, adrenal adenomas and carcinomas tend to be the cause in 10 to 15% of the cases. ectopic ACTH production, just like in case of ACTH secreting tumor, stimulates the cortisol release from the adrenal gland without the normal negative feedback loop because the source of ACTH is outside the pituitary gland. Now, more than two-thirds are the small cell carcinomas of the lung. Bronchial carcinoid and thymoma may be the cause. The clinical features are metabolic syndrome like hypertension, hyperglycemia, hyperlipidemia, obesity. Okay, just remember the moon facies. So M for metabolic syndrome, O for obesity, another O for osteoporosis, N for neuropsychiatric conditions, F for facial plethora, A for androgen excess, C for cataract, I for immunosuppression, E for ecchymosis, and S for skin changes. Now, the metabolic syndromes are the hypertension, hyperglycemia, and the hyperlipidemia. So, you know that in case of Cushing syndrome, there is increased production of the adrenal gland hormones, like, so if there is increased production of the glucocorticoids, then the patient will have hyperglycemia, right? Now, if there is obesity, the patient generally have obesity. So if there is truncal weight gain with wasting of extremities, and the patient will have rounder moon facies, then that is a typically manifestation of the Cushing syndrome. And if there is high level of steroids, then obviously that will lead to the bone resorption, and then there will be osteoporosis, and there will be depression, anxiety, and irritability sort of conditions, and there will be acne or hirsutism, or there will be cataract due to the increased glucose. And if there is increased steroids, then obviously steroids is an immunosuppressant, so there will be immunosuppression, and the patient is immune just susceptible to diseases, right? And if there are ecchymosis, the patient will be having easy bruising, and if there is increase in ACTH production, then obviously the patient will have also the increase of melanocyte stimulating hormone, which will just cause hyperpigmentation, striae, or thinning of the skin, or you can just say skin changes. So these are the features of the Cushing syndrome here. Now you can see the moon facies, the muscle wasting, the abdominal striae that are there, the central obesity, the bruising due to the chymosis, and then there is the supraclavicular flat pads, and this is the dorsocervical flat pad or the buffalo hump. Now, talking about the ACTH dependent and the ACTH independent causes of the Cushing syndrome. So, in ACTH dependent cause, we have Cushing disease and ectopic ACTH syndrome. So, Cushing disease is pituitary ACTH hypersecretion, and ectopic ACTH syndrome is paraneoplastic ACTH secretion. So, the pathologic findings of these ACTH dependent as conditions include the bilateral hyperplasia involving the zona fasciculata and zona reticularis. Talking about the ACTH independent sort of Cushing syndrome, we generally have adrenal adenoma or carcinoma. So the pathological findings will be just like benign tumors, which are typically round, well circumscribed lesions with the small cells, which are similar to the zona fasciculata. There are malignant tumors that are often irregularly and poorly demarcated with considerable cellular pleomorphism. The atrophy of the zona fasciculata and reticularis in the uninvolved cortex region. Right, this is how you diagnose the Cushing syndrome, and this is how you rule out Cushing disease and all from other conditions. So, if there is increased 24-hour urine-free cortisol, or if there is increased late-night salivary gland cortisol, so this is the picture just from your first aid, then you need to measure the serum ACTH. Now, if the serum ACTH is suppressed, then you need to think of the ACTH independent Cushing syndrome. So maybe the patient is taking some amount of exogenous glucocorticoids, or there is a corticoid secreting adrenal functional tumor, which is causing the negative feedback and leading to the decreased or suppressed ACTH. Then you need to confirm with adrenal CT scan. Now, if the ACTH is elevated, then you need to think about the ACTH dependent Cushing syndrome. So if there is ACTH elevation, then you need to go for the high dose dexamethasone suppression test. If there is no decrease in the ACTH level, then you need to think that there is some source of ectopic ACTH secretion. If there is decrease in ACTH level, then you need to think about the Cushing disease, okay? That means that the patient has functional pituitary secreting adenoma. You also need to do the CRH stimulation test, or the cortisol releasing hormone stimulation test. If after that test the ACTH is elevated, then you need to think about the Cushing disease. If it is not elevated, then you need to thinking about the ectopic ACTH secretion. So in cases of ectopic ACTH secretion, you need to again to do the CT of the chest, abdomen, and pelvis to find what is the source of that ectopic ACTH secreting tumor. Now, this is again a simplified chart from your own U world. So diagnosing the cause of Cushing syndrome, you need to check the ACTH levels. If it is suppressed, then maybe the patient is having adrenal adenoma or adrenal malignancy, which are functioning, or the patient is taking some exogenous glucocorticoid intake. Or if ACTH is normal elevated, then you need to do the high dose dexamethasone suppression test. If the ACTH levels are suppressed, then you need to think of the pituitary adenoma. If the ACTH level and cortisol levels are unchanged, then you need to think about the ectopic ACTH production. Now, talking about the treatment of the Cushing syndrome. So in case of iatrogenic Cushing syndrome, you need to do the tapering of the glucocorticoid. And in case of pituitary Cushing's disease, you need to do the surgery, which is transsphenodal ablation of pituitary adenoma, which is usually safe and effective. In case of adrenal adenoma or carcinoma, you need to again do adrenectomy. And when surgery is contraindicated or unsuccessful, or the patient is awaiting surgical treatment, then you can start with some medical therapies like adrenal enzyme inhibitors such as ketoconazole, which can inhibit the synthesis of cortisol and thus can be used as medical therapy. Now let's talk about one more question before we finish this lecture. So examination of this patient's adrenal glands is most likely to reveal which of the following findings. So a 45-year-old woman calls 911 due to severe chest pain and dyspnea. The emergency medical team finds the patient unresponsive with no pulse, and she does not revive despite extensive cardiopulmonary resuscitation efforts. Now, she had a prolonged history of systemic lupus erythematosus, treated with multiple medications, and was recently evaluated for progressive muscle weakness. Now, the records from the patient's most recent office visit show an elevated blood pressure and examination findings of facial plethora, truncal obesity, and skin ecchymosis. She was found to have a mild hyperglycemia too. Now, the medical history included a cleft lip, included a left hip replacement for osteonecrosis of the femoral head 1 year ago. At autopsy, he is found to have an occluding thrombus in the left main coronary artery, which likely led to sudden cardiac death. Now, examination will reveal what? Adrenal cortical adenoma, bilateral cortical atrophy, a diffuse cortical hyperplasia, diffuse cortical hypertrophy, or nodular cortical hyperplasia. So what do you think is the answer? Just pause the video and ask yourself. So before you move forward with the answer, the first thing you need to do is you need to understand the separation of the hypothalamic pituitary adrenal axis. So whenever we prescribe the patient exogenous glucocorticoids, that's exogenous glucocorticoids will ultimately have a negative feedback on the paraventricular nucleus of the hypothalamus and also the anterior pituitary. And that will lead to the negative separation, or that will lead to just the separation of the ACTH release. And if the ACTH is not released, then the adrenal cortex will not produce the hormones. So if we prescribe prolonged exogenous corticosteroids or exogenous glucocorticoids, then there will be prolonged decrease in the ACTH secretion. If there is prolonged decrease in the ACTH secretion, then obviously the adrenal gland, due to the disuse atrophy, the adrenal cortex will just go under atrophy. So the explanation is B. So this patient has a feature of hypercortisolism, including hypertension, central obesity, muscular weakness, ecchymosis, and hyperglycemia. So she most likely developed iatrogenic Cushing syndrome due to the prolonged administration of glucocorticoids for the management of SLE. Now, the chronic glucocorticoid use can also cause osteonecrosis, and both Cushing syndrome and SLE itself can cause the risk of atherosclerosis and acute coronary event as in this patient. Thank you for watching. We will again back in the next video with another super duper concept. Thank you all.